Good morning, everyone. I think we'll get started now. My name is David Wetzel. I'm Chief Medical Officer for the Hospital and Specialty Services. I'm here this morning to welcome you to Grand Rounds, a special Grand Rounds in honor of Dr. Peter Holbrook. Dr. Holbrook dedicated 37 years to the Children's National Health System, and 17 of those years were as Chief Medical Officer. When he announced that he would be leaving Children's National, the faculty, board members, other members of the Children's National community came together very quickly and created this endowed lecture in his honor. Peter began his career at Children's in 1975, and he reminded us last night at dinner that he started by putting together 5 or 6 beds in the library of the old hospital. He was joined by partners like Bert Epstein, who's here with us today as Chief of Anesthesiology, Alan Fields, and other co-faculty in the Pediatrics Department. He was named Chairman of the Department of Critical Care Medicine in 1986, and in 1995 he was appointed Chief Medical Officer. Peter Holbrook has made seminal contributions to the field of pediatric critical care medicine. He's helped shape that field, especially as it relates to the training programs in the departments of pediatrics for fellowship training programs in critical care. He was the first chairman of the subcommittee for pediatric critical care in the American Board of Pediatrics. He was one of the early presidents of the Society of Critical Care Medicine. He wrote one of the first textbooks in pediatric critical care, if not the first textbook, and he really made many important contributions to the field. This morning is World Sepsis Day, so we're going to honor Peter by having something that represents a disease that he spent many days, many nights, and many years treating patients with severe sepsis. We have 3 speakers this morning. The format's a little bit different than it is at other times. We're going to begin with an introduction to what Children's National's effort toward identifying sepsis in our hospital is, and the collaborative effort there, and that's going to be led by Dr. Robin Steinhorn, who's here with us in the front row. After Dr. Steinhorn's remarks, we're going to have another expert. This is a different kind of expert, not a scientist or a clinician, but a parent of a child who was in our ICU with severe sepsis. And Mr. Mark Miller is here to tell us about his journey in the ICU, seen through the eyes of a parent. And then after Mr. Miller, our main speaker today, our invited guest, is Dr. Jerry Zimmerman. Dr. Zimmerman received his bachelor degree and his PhD degree and his MD degree from the University of Wisconsin. He describes himself as a Badger, spent many years there in his training and continued. I see some fans in the audience here. He continued his pediatric residency there and then came to Children's National at the time when there were really just the beginnings of fellowship training programs. He trained here with Peter Holbrook, Mary Pollack, Alan, and others. And then went back to Wisconsin, and about 20 years ago was recruited to Seattle Children's Hospital, one of the great pediatric hospitals of the country, where he was chief of critical care medicine there for many years. He's developed an important network of clinical research in sepsis, belongs to many of the national networks, and is a real important force and has become the international expert in multi-organ system failure in children and pediatric sepsis. He's also written a textbook that is in, I think it's 5th edition now. It just came out with the Pediatric Critical Care textbook in the 2017 edition, and is the rising president of the Society of Critical Care Medicine, which is the main society for critical care, including pediatrics, in the United States. So we'd like to acknowledge this morning Dr. Holbrook, who is with us, and our speaker, Dr. Zimmerman. So please join me in a round of applause. So at this point, I'm going to turn the podium over to Dr. Robin Steinhorn, followed by Mr. Miller, and then Dr. Zimmerman.
So thank you so much, and I just want to say what honor and a privilege it is to be here with you today for the lecture honoring Dr. Holbrook, who was and is such a giant in the field. As Dr. Wessel said, this is World Sepsis Day, and I just want to frame the hour we're going to spend focusing on the impact of sepsis on the work we are doing here at Children's National, and will really be emphasizing over the next couple of years. So we are part of a collective with the Children's Hospital Association that's called IPSO, so Improving Pediatric Sepsis Outcomes. And as is true for many of the CHA initiatives, this is viewed as an all-teach, all-learn collaborative. In other words, anybody who is participating is not only learning but teaching others, and this really crosses all disciplines. There are 25 hospitals that are participating, and it's a real point of pride that Children's National has already been a key participant. So there was a rapid cycle collaborative that was largely led by Kathy Brown from our emergency department, and over the last several years, there's now a Pediatric Septic Shock or Severe Sepsis Collaborative, and that's what our focus will be in the coming years. So a snapshot of our data is, of course, important because you can't manage what you can't measure. And so for those measurements, we're very grateful to Neil Badarai, who I think is in our audience, who has done that deep dive of our data. There he is, clapping around him. So Neil was able to do a deep dive into our EMR and identify over 2,000 non-severe sepsis episodes. About 10% of those originate in our emergency department, meaning that many of them are originating on our acute care wards and in our ICUs. Of those, 930 met the definition for severe sepsis or septic shock, and by that I mean an episode that required cultures and antibiotics and was associated with the need for inotropic support or fluid boluses to maintain hemodynamic stability. And we're really here just focusing, I'm a neonatologist, so I have to say none of these are NICU babies. All of these are non-neonates. Now, of those 930, we had 23 deaths. And think about that. We lose 2 children a month here with a death that is either due to or was associated with an episode of severe sepsis within 30 days of their death. So this is a real problem, and it's a big problem for us, and it's one that I'm very proud to be one of the sponsors to help tackle. So we will be joining the overall global aims for reducing severe sepsis. And these aims by 2020 are to reduce mortality by 75% in U.S. pediatric acute care settings. So we're going to take that 23 patients and we're going to reduce it, and we're overachievers here, so we're going to reduce it by more than 75% and have the minimal mortality we can possibly achieve. And to do that, we're also going to decrease the incidence of hospital onset sepsis in our U.S. pediatric acute care setting by 75%. So we're going to take that 930 and reduce it, and we're going to take that 23 and eliminate that. So to do that, I'm partners with Rahul Shah, who could not be here today to lead the team. What I want you to notice from here is that everyone in this audience and beyond is going to have a role in achieving this big goal. So there will be implementation teams across the entire hospital, a coordinating council with representation from those teams. And so our strategy here is going to be early recognition throughout the house. Early recognition will lead to early resuscitation, early rescue of these patients, and that's going to lead to a greater degree of full recovery. Now, my words hopefully frame your thoughts But to really understand the impact of pediatric sepsis, I'm going to turn the podium over to Mr. Miller, who's going to tell us what it's really like to be sitting at the bedside.
Thank you. So Dr. Wessel mentioned that I'm a grateful father, but I'm also an employee here. I've worked here for 10 years, and I'm really honored to be part of anything honoring Dr. Holbrook, because I've always thought that he embodies what Children's National is all about. I also want to thank Dr. Wessel for asking me to share my story, and more important, to thank him, Dr. Christy Corvo, and the entire PICU team for literally saving my daughter's life just about 1 year ago. This is my daughter, Chloe. She's 13 years old now. She was 12 when this happened. She knows Children's National really well. She has autism, she's nonverbal, and she has a seizure disorder that's currently under very good control because of our neurology team here. She's also a happy child with a great smile, as you can see from this photo. So Chloe's been hospitalized a few times, including some time in the ICU, but her experience with sepsis was unlike anything we had seen before. She went to school on Friday, and this is a photo that her teachers happened to send us that day. This is her at school on Friday. Everything was fine. She came home, and she was tired, and she could barely walk up the steps to her room to rest. She was so weak. She had a fever. We were able to give her Tylenol, and the fever came down. But before long, she was completely unresponsive. We couldn't wake her up, and we knew we'd seen her sick before, but we knew something was wrong. And we took her to our local emergency room, which is Holy Cross. They immediately saw that because of her blood pressure and just because of what she looked like, she needed to go to Children's. She had influenza A, pneumonia, and strep. So all of that hit her at the same time. My wife was the one who took her to the hospital, and by the time I got here, this is what I saw. She was wearing a BiPAP mask, but she was breathing really fast. And except for the fact that she was breathing, she looked completely sedated. Even though I had seen her sedated after having seizures at the hospital before, I was really stunned to hear that she wasn't on any sedatives at this time. She didn't react to the bright lights of the ICU. She didn't react with blood draws or having IVs in her arms and legs. The fact that she couldn't feel any of that was something that we had never seen before. So something about family-centered care. When they talked to us about intubating Chloe, we told them that several years earlier she had a bad experience with intubation. Dr. Corvo decided to make that a last resort, and I later found out that intubation is a standard protocol for someone in her condition, but they listened to us, and Chloe was able to breathe the entire time she was there. So she didn't require intubation, and that was only because we gave them that insight. We hear a lot about family-centered care, but it really does matter to listen to parents who best know their children and best know what their baseline is. So she was treated with antibiotics, oxygen support, blood and platelet transfusions, and one of the first milestones here is on the 4th day, she opened her eyes. So this was the first time we saw her with her eyes open. She was breathing a lot better, and she was transferred to the 7th floor. She was in the hospital for a total of about 2 weeks. Another important milestone is day 9, she smiled. So again, getting back to her baseline of she really is a happy girl and just feeling normal again, she was very happy about that. Dr. West asked me to talk a little bit about the recovery, and this whole experience really wiped us out, our whole family. Chloe probably rebounded better and faster than the rest of us. This is her school photo 1 month after she got out. She came home, so this happened Halloween. She was in the hospital for 2 weeks. We kept her home until after Thanksgiving. She went back to school. She had all of her energy, her mood, everything was back to normal. But for us, we'd been through this traumatic experience heading into the holiday season, and it was really months, I think, before we felt completely recovered from all this. When you're dealing with it in the moment, you don't really understand the toll that it takes. And it wasn't until we got out that we actually realized how serious this was. And because it's World Sepsis Day, I think it's important to say that we don't remember hearing the word sepsis until she was getting better. So I remember a doctor saying to me on about the 4th day that Chloe's out of the woods, and my first reaction is, was she in the woods? Because my wife, who I thought was being overly dramatic, said, I feel like I just need to be there. If anything happened, I would never forgive myself. And I'm like, oh, she's fine. Like, the doctors here are great. The nurses are great. They've got a plan A. They've got a plan B. And I'm kind of glad I didn't hear the word sepsis, because I would have immediately Googled it and read about mortality rates, and it's probably good that we didn't know. But at the same time, the doctors and nurses did answer all of our questions throughout the entire episode, and it was as positive experience as it can be for something this dramatic. So I really appreciate the opportunity to share this story, because it has a positive outcome, and it really demonstrates the expertise and commitment of our entire team. You all care not just for children, but entire families. And I just want to thank you for everything you're doing about sepsis, but also just across the board. It's just a wonderful organization, and the people here are great, and I have a new appreciation, especially for the PICU. So thank you. And now it's my pleasure to introduce Dr. Zimmerman.
All right, good morning, everyone. First of all, thanks for taking time out of your day to attend Grand Rounds, and thank you for inviting me to present Grand Rounds on World Sepsis Day in this setting of the Holbrook lecture. I really appreciate the invitation, and I have been treated royally. My disclosures, the only things that might potentially be relevant is the fact that I have received some research funding from a local biotech company in Seattle called Immune Express, and I'll tell you a little bit about that later. And then I've received some educational materials from the Sepsis Alliance, and we'll share these with you and tell you about them later in the lecture. These are the things that I would hope that you would get out of this lecture today. And the first is actually understanding the impact of sepsis in terms of both mortality and morbidity around the world. Acknowledge the importance of early infection recognition. If you don't pick up on anything else, that is the key message right there. Recognize the value of clinical standard work or bundles for sepsis treatment. And then lastly, appreciate that sepsis begins and ends outside of the ICU and outside of the hospital. So I was asked to start with a case report, so here it is. A 3-year-old comes into the hospital, has a history of not being immunized. Maybe that doesn't happen here, but it certainly happens in Seattle. And this child is admitted with septic shock and multiple organ dysfunction syndrome. By any account, this child is sick. Either by an illness severity score like PRISM or an organ dysfunction score like PLOD, or even biomarkers. Let's just say the lactate was 6. So this child is sick. During his course in the hospital, this patient received appropriate antibiotics, mechanical ventilation, vasoactive inotropic support, and even a few days of renal replacement therapy. During his stay in the ICU, the nurses commented several times that this patient exhibited delirious behavior. In total, this patient spent 2 weeks in the ICU and 3 weeks in the hospital, and eventually was discharged to his home under the care of his parents and his primary care physician. And when all was said and done, everybody stood around and patted each other on the back and said, "This was a great save." Hold that thought. So here is the burning platform for what we're here to talk about today. In the world, every 5 seconds, someone dies of sepsis, and half of these deaths are children. So let's start by talking about what we're talking about. As of 2016, there's a new definition for sepsis, and it really consists of 4 parts, and they are, as you can see here, the fact that it is a life-threatening syndrome involving organ dysfunction, and it is thought to be caused by a dysregulated host response, that's the 3rd element, to an infection. So this is a clinical definition with clinical criteria that we'll look at in more detail in a little bit. But this replaces the old sepsis definition that was based on elements of the systemic inflammatory response syndrome. Just a little bit of epidemiology to give you more scope in terms of what this is all about. Sepsis is the leading cause of death and probably disability, we just haven't looked, for children worldwide. In the United States, there's about 75,000 cases of sepsis annually with a 5 to 10% mortality rate. So there are 4,000, 4,200 children that die of sepsis in this country every year. And the cost for the care of these children now exceeds $5 billion annually. People talk a lot about cancer, and certainly that's a big problem. But there are more kids that die of sepsis than die of cancer. And some kids who die of their cancer die of sepsis. So this is an important problem, not only in the United States, but everywhere in the world. So starting at the beginning, it is sometimes difficult to recognize what turns out to be very important early on. This is a 38,000-foot view of what sepsis is about, the major parts of this triumvirate. And the first is public health interventions. It's going the wrong way, folks. All right. All right, I need to get back. Sorry. The first are public health interventions, things like sanitation, good nutrition, vaccinations. Ultimately, these are the most important things in terms of public health things that actually prevent sepsis. The second thing, which I will talk about over and over again, is this timely identification of infections and initial intervention as soon as possible. And then lastly, for children and adults with the most severe forms of sepsis, care for multiple organ dysfunction syndrome in an intensive care unit. So I want you to remember the base of this triangle, because this is what we're really here to talk about today, or at least I'm here to talk about today, this early identification of an infection, because if that happens, then you can interrupt this transition to sepsis, which is an infection involving multiple or single organ dysfunction. So if we can focus ourselves and our parents and families and the public at the base of this triangle, we have the ability to make a real impact on sepsis outcomes. This isn't rocket science. People talked about this years ago. So here's Machiavelli and his treatise on the Prince, and he's describing hectic fever, and almost certainly this was septic shock. And he said that early on, this syndrome of hectic fever is difficult to diagnose, but would be easy to treat. But if things are left to their own, ultimately it becomes easy to recognize, but then much more difficult to treat. So the idea is to transition from actual sepsis with organ dysfunction, move back along that timeline to early recognition of the infection. The problem is that there is a communication disconnect in pediatrics, particularly with our families, because there's a big segment out there that believe that sepsis only occurs in the hospital, and about the same proportion, as you can read up here, also believe that you can get sepsis, but it's probably usually not going to be that much of a big deal. When in reality, 90% of cases of sepsis occur in the community before they arrive at the hospital. And even in the United States, your risk of death from severe sepsis is about 10%, and there's a huge burden of mortality, morbidity among the children who end up surviving their sepsis, and I'll give you more information about that shortly. So, in conjunction with World Sepsis Day and Sepsis Awareness Month, September 2017, the CDC has launched this campaign, this marketing campaign, to increase awareness of sepsis in the United States. And it is called Get Ahead of Sepsis. Again, referring to moving that transition from sepsis back to recognition of infection. There are three parts to this: is know the risks, and this is a potentially lethal disease. Just don't treat it casually. Number two, spot the signs, and this information on these cards, which we're going to talk more about. Please pick one up because you can share this with the families that you treat. And then act fast. If you are in a scenario or a parent where sepsis is suspected and nothing is happening, someone has to stop the line and say, could this be sepsis, and should we be doing something like right now? So that it may be easier said than done of actually identifying these early infections, and this is like finding the needle in the haystack. And in fact, this is the, I would say, quintessential pediatric diagnostic problem. Finding this kid, usually it's an infant or a toddler who doesn't say much, finding this child with bacterial sepsis in the midst of this epidemic of viral upper respiratory tract infection. The ED person or the primary care physician who can do that is really to be honored, because it is so important to identify these children early. Going back to that sepsis 3.0 definition, this is a clinical definition. The authors, and by the way, this really all relates to adults who are no neonatologists or pediatric critical care or infectious disease people invited, but suffice this to say that they based people getting sick with their sepsis on clinical criteria. They used the sequential organ failure assessment and a shortened version of that. And they also compared this diagnostic capability of this new definition utilizing other clinical criteria like elements from the systemic inflammatory response syndrome or the logistic organ dysfunction score. But in the end, you can take these alone or mix and match these clinical criteria, and the best that you can do in terms of area under the receiving operating curve for diagnosing sepsis is about 0.7 to 0.8. So it's okay, but the message is here that there still is a big void in terms of good sensitivity and specificity for diagnosing sepsis utilizing clinical criteria alone. So some people who are interested in this have more recently said, well, why don't we add some biomarkers to this diagnostic dilemma? Perhaps we can improve both sensitivity and specificity. So the first thing I'm going to show you is looking at more rapid diagnosis of the infectious agent. And this is just one example that tries to improve on the gold standard that is currently culture. Culture frequently provides false negatives, false positives. It's relatively slow, although certainly better than a decade ago. But here's some new technology. It utilizes polymerase chain reaction to amplify bacterial DNA, for example, from a blood sample, and then it uses mass spectroscopy to analyze this bacterial DNA. And you probably can't read this, but the value of this test is that the negative predictive value is 97%, meaning if this test is negative, the likelihood of an infectious agent causing the symptoms in this patient is very highly unlikely. The other thing that's good about this new technology in terms of microbe identification is that it also provides information about the antibacterial susceptibility of the organism, and in an ideal state, the turnaround time is going to be 4, 5, or 6 hours, not 1 or 2 days. So I think eventually this is going to be our gold standard, but there's still a ways to go. On the other hand, we can also, instead of looking at the microbe, we can look at how the host responds to this infectious insult. So on the screen now is a summary of a study undertaken by the PCARN network. These are the Pediatric Infectious Disease Emergency Room Physicians Research Network. And they directly examined this question of identifying bacterial sepsis in infants. So they accumulated a cohort, I believe, of 64 kids who presented to the ED with concern for sepsis. They're all less than 60 days of age. They all received blood cultures, started on antibiotics, and they also underwent leukocyte fractionation, messenger RNA extraction, and then assessment of their messenger RNA signature for 3,753 gene expression signatures. And what you see up here on the left are these 19 control kids. They presented looking like they might have an infection. They might even probably met some of the clinical criteria, but ultimately on blood culture were negative. And you can see the expression pattern for these near 4,000 genes. It's rather an indifferent expression pattern, neither increased or decreased. This is compared to these kids on the right. These are 45 infants with ultimately culture-proven bacterial sepsis. And you can see that there's a large chunk of genes that are upregulated. This is orange or red, and an even greater number of genes that are significantly downregulated. So these children are behaving very differently. And look at the sensitivity and specificity here. It's almost 90%. So there is value at looking at how the host actually responds to this infectious insult. But we are interested in this in Seattle as well, starting with the fact that if you want to make a point-of-care device that you can actually use in the ED or in the ICU or on the HEMONC ward, you can't really have almost 4,000 genes. So this company in Seattle derived this product called Septicite Lab. This is a 4-gene expression signature. 2 genes that are highly upregulated in sepsis and 2 that are highly downregulated in sepsis. This was derived in adults and then validated in a number of studies in adults. And this is just a summary of a pilot investigation that we conducted on children utilizing the same gene signature expression. And in this initial study, which you could say is somewhat contrived, we looked at 35 kids with, I would call it, overt clinical septic shock. They're all in the ICU. They've been cultured. Most are on vasoactive support. Almost all are on the ventilator. And we compared these with an infection-negative group of children with systemic inflammation. And these were 35 kids who just were admitted to the cardiac intensive care unit after being on cardiopulmonary bypass. In one hand, the systemic inflammation is caused by plastic in the cardiopulmonary bypass machine. and in the other from infection. So there is a very nice differentiation between these two groups with this 4-gene signature. Here, the area under the receiver operator curve is way beyond 0.9, and at least for this controlled experiment, there is both high sensitivity and specificity in differentiating these two types of systemic inflammation. These same guys at Immune Express then used existing messenger RNA databases to derive a second gene signature, and this is for children or adults with severe viral infection, because that is an important differentiation for pediatricians particularly. These people identified, again, a 4-gene set, 2 upregulated, 2 downregulated, and they went through all the data that was available in terms of gene expression for all 7 Baltimore viral classes. So not just respiratory syncytial virus, but really almost any viral infection. And here's what they found. This second product, which was called septicite virus, as you can see here in this 3-dimensional depiction, really separates out children with non-infectious SIRS from children with severe viral illness, and then in green, coming around here, children with bacterial infections. So this is new technology. It works. We have plans to try to validate this and see if the test works in a more generalizable fashion, like not in the ICU, but does it work and perform in the emergency department. The ultimate task will be getting this into a point-of-care device, and there are engineers working on that. So that's diagnosing sepsis. Turns out that you can use this same approach, what is the host doing with infection, to predict how patients are going to do based on how they respond to the infectious agent. So what you see here is one summary of work from Hector Wong's group based out of Cincinnati and the Research Network. He, from the beginning, and this has been going on for at least 10 years, is interested in differential gene expression in sepsis, again in children. And he has focused on 100 genes that are, some of them upregulated, some of them downregulated. And as he's been working on this, he's noted that these clinical patients fall into 2 categories. You can visually see the difference between these 2 groups, endotype A and endotype B. And it turns out that these kids in endotype A are younger, they have greater illness severity, and if they persist during the course of their sepsis, day 1 versus day 3, they persist with this endotype, they are at significantly increased risk of death from sepsis. It also turns out, and I think this is really neat, is if you treat these children who are sick with their septic shock with corticosteroids, they are actually harmed by this treatment. They have an increased risk of mortality. So why would this be? It's right there before you. If you look at the endotype B patients, you can see that they're doing all kinds of things. Some genes are highly upregulated, some genes are highly downregulated. There's some that are sort of indifferent. You look at the kids in the endotype A cohort, what you see there is mostly blue. This is a cohort of children that is severely downregulated in the gene expression pattern of these 100 genes. And if you ask what genes are you looking at, they're all about adaptive immunity. So sepsis itself represses gene expression along the adaptive immune pathway and innate immunity for that matter as well. But corticosteroids add significantly to that repression. So here's personalized medicine. And for once, pediatrics is leading the way. This is really neat stuff that hopefully will guide our practice in the near future. Identification, we've talked about that. Now it's time to do something. And it turns out that probably every hour matters. Sepsis is not unlike trauma. There is a golden hour in which, if things get done in a timely fashion, outcomes can be effective in a very positive way. And this then comes into the concepts of bundles of care or clinical standard work for sepsis. And if we want later, we can debate whether as a whole this is beneficial. But remember, in that discussion, we would be comparing 2017 to a long time ago, almost 30 years, when this concept of using a bundle was first introduced. We now practice all aspects of medicine utilizing clinical standard work. There really are four main aspects of the early intervention, resuscitation of sepsis, and that is fluid administration, identifying the source and controlling it and starting antibiotics, and then addition of vasoactive inotropic support. Whether the bundle as a whole nowadays makes a difference, as I said, is debatable, but there's no question that antibiotics as part of this bundle, early administration of antibiotics and identification of the source of the infection is key. And earlier administration of antibiotics results in better outcomes. We've also learned, contrary to the past where I taught and I said you can't give too much fluid for sepsis, that's clearly just wrong. We now know that a persistent positive fluid balance in patients with sepsis after the first couple of days is associated with poorer outcomes. So we certainly need to fill the tank in terms of hemodynamic resuscitation, but people are turning earlier, more quickly, to vasoactive inotropic support for hemodynamic resuscitation in these patients with septic shock. So Robin already talked about what you're doing here in terms of the IPSO collaborative. These are pretty audacious goals: reduce sepsis mortality, in-house mortality by 75%, and reduce the in-hospital occurrence of severe hospital sepsis by that same percentage. I think it's great, and if they achieve even a fraction of what they're setting out to do, this will make a huge difference. The two things that I think are most important for this collaborative are the fact that this clinical standard work or bundles are based on the best evidence that is currently available. And the other thing that is neat about this is all of the educational resources that are part of this. And if you have any interest in sepsis, you should get involved, because there are phone conferences, webinars, face-to-face meetings, all aimed at earlier recognition and treatment of children with sepsis. For those patients who require more than just initial resuscitation, they will typically end up in the intensive care unit. And I think this quotation, to know sepsis is to know critical care, rings true, because what is happening in the intensive care unit is resuscitation of multiple organ dysfunction syndrome and how these things interact with each other. This process is driven by these reciprocating insults of inflammation and ischemia, dysoxia. One begets the other, and this is associated with multiple organ dysfunction syndrome. If you're a child and you're going to die of sepsis, either you have a failed resuscitation or you have multiple organ dysfunction syndrome in the intensive care unit. So what are the intensivists doing? They do what they always do. And what we do in the intensive care unit is we facilitate oxygen delivery. That's what we really do. We don't really have very many magic bullets, although you'd say antibiotics might fall into that class. But here's what we do. we facilitate oxygen from the atmosphere into the lungs, onto the red cell. This oxygen is transported on hemoglobin with adequate cardiac output, delivered to tissues, in this case cardiac muscle, where myoglobin facilitates the exchange of oxygen into the mitochondria, where it acts as the terminal electron acceptor for efficient ATP production. And organs like the brain and the heart and the renal collecting system need this to be happening constantly. And without this flow of oxygen to the mitochondria, things go bad very quickly. So what intensivists are really doing, and probably nobody has seen this kind of talk except for Peter, Alan, myself, and Murray, is we resuscitate the dysoxias. And what the heck are the dysoxias? Well, there's 4 of them: hypoxic, anemic, stagnant, and cytopathic. So we have a ventilator to improve gas exchange in the lung. We can transfuse blood cells if content is not adequate. We certainly can help the heart and the microcirculation with volume replacement and vasoactive inotropic support. But we really don't have any tools to address this cytopathic dysoxia. And what the heck is it anyway? Well, cytopathic dysoxia is the fact that your cardiac index may be perfect, may be high, but the lactate is going up. The peripheral tissues are just not utilizing lactate, utilizing oxygen. And in this setting, if your patient shows this particular pattern, this is dire straits for this patient because, as I said, we really don't have a good way to treat this. It reflects a damaged electron transport chain uncoupling of oxidative phosphorylation. And people who are working on this, for example, Scott Weiss in Philadelphia, some people believe actually that this is an adaptive mechanism, that the body is trying to facilitate mitochondrial hibernation for a period of time to reduce energy consumption by the body in total in a last-ditch effort to ultimately preserve the viability of the organism. Recognition, initial resuscitation, may be involving the ICU for the severe cases. So what happens next? What about the child after leaving the hospital after an episode of sepsis? So this is the big picture. In 2017, the mortality risk for septic shock is the best estimates I can give you is 9.1%. But there's also a huge morbidity burden that heretofore has really not been described very well. There is certainly, with the increasing incidence of sepsis, that's a true fact, and decreasing mortality, there's this space in between of children that carry with them a severe morbidity burden after they leave the hospital. In fact, this is a quote that I actually believe in: quality of life has become the new survival in pediatric critical care medicine. Not to diss the fact that survival is important. It clearly is, and there have been clear gains in this regard. In the 1950s, 60s, mortality from pediatric septic shock was 50 or 60%, and now it's about 10%. But there is a big mortality burden that we need to pay more attention to. This is a conceptual framework of this idea of people who require hospitalization. And what you see here in yellow is the patient with their symptoms, for example, in the intensive care unit with their organ dysfunction, and ultimately proceeding over towards the right. We are happy when we turn off the epinephrine and stop the renal replacement therapy and extubate the patient. That's important to the patient, but it's not nearly so important to the patient as how they view their ultimate quality of life. And along this trajectory, there are characteristics of the individual as well as the environment in which that individuals find themselves that can alter this trajectory of recovery or not. So I am happy to report that there is an NIH-sponsored trial that specifically asks the question, what is this morbidity burden among children who survive their sepsis? And what are the factors in the intensive care unit of the individual and of the home that affect how these kids eventually turn out? There were 392 children who were entered into this study and among 12 hospitals, and we are now in the final year of looking at the follow-up of the kids who were enrolled during the 4th year. None of this data has been published or not even presented in abstract form, but I just wanted to tantalize you because I think this is an important finding. These children were followed from their presentation and then serially evaluated at 1 month, 3 months, 6 months, and 12 months. And what you see on the ordinate or y-axis is the percent of these kids evaluated with the Pediatric Quality of Life Inventory tool, proxy report by their parents, this quality of life measurement over time. And these are the kids who persist below their baseline. So the important takeaway message here is even at 12 months out, about 1/3 of the cohort studied with this tool are still not back to their baseline quality of life. And I don't think anybody knows about that. And these kids certainly deserve some type of an intervention way back here after they leave the hospital to get them back closer to where they started. So these children following sepsis have long-term disability. They're at risk for a hospital readmission, interestingly, often associated with another infectious problem, and they are also at increased risk for late mortality after the index sepsis admission. So I would say that it's safe to say that a good save is no longer good enough. Of course, survival is important, but our patients should be thriving, not just surviving. Ultimately, beyond survival, maximizing quality of life may be the most important goal that we should be looking at. Lastly, all of us, most of us in the United States at least have potential access to good health care, especially if we, for sepsis, recognize it and engage in that healthcare system. But this is not true internationally. So it's not surprising that this year the World Health Organization published this resolution, which you can look up if you are interested. But basically, they make this statement that sepsis needs to be brought into the public and political arena if people really want to see things change for these 3 million kids who die annually of sepsis worldwide. They suggest that governments everywhere strengthen their policies and processes related to sepsis, particularly to develop the infrastructure so that there is access to quality, safe, efficacious, and affordable sepsis treatments. So I would urge anybody who has a global medicine interest to look at this website and see if there are ways to become involved. And lastly, if you haven't picked up one of these cards from the Sepsis Alliance, who provides this free educational material, do so. Pick up a few of them. I don't want to take any more back to Seattle. And don't put them in your purse or your pocket. Give them to your patients. The purpose of this card is to know sepsis, K-N-O-W. That's part of it. And the other part is hearken back to that triangle and the base of the triangle. And on the left is identification of infection early with an arrow pointing towards organ dysfunction and severe sepsis. And with this early recognition of infection and early treatment, hopefully we can get to a better place where we have no sepsis, that is NO sepsis. Thank you very much for your attention. I am happy to take any questions.
Thank you very much, Jerry. I think we could just take one question right now from the audience. I want to remind people that we're going to have a reception with Dr. Holbrook, Dr. Zimmerman in the mini atrium, which is just out the door and to your left across the cafeteria. There'll be a reception there for everyone to catch up with what Peter's doing, as well as ask further questions for Dr. Zimmerman. But is there one question from the audience? Dr. Batshaw, to you.
Thank you. It's wonderful and very important talk, Jerry. Could you speak to what are the most common organisms that we're seeing in the United States causing sepsis, and what are the most common morbidities that we're seeing after sepsis?
So the question is, what are the most common organisms that we see in sepsis, and then what are the most common morbidities? The answer to the first question comes in two parts. It depends on whether you're a previously healthy kid, and those are still the same organisms that we used to treat, meningococcus, H-flu, and streptococcus, pneumococcus, at least for older kids. And that involves being young and not having your full immunization set, or never having them at all because your parents don't believe in it. And then there's this other group of HEMONC, solid organ transplantation, immunosuppressed kids who have every organism, a lot of gram-negative stuff with central line infections. I think that's true. The morbidities, it turns out that this quality of life, again, this is preliminary data, but the signal is in the physical component. These children are probably weaker. They're probably not physically active like they were before. They're not engaging in play with their friends, and they may be staying home and not going to school. I haven't gone into this in detail, but there is a big signal in the physical component of, physical dimension of quality of life.
So thanks to all of our speakers.